Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
Welcome to Oncology, Etc., an ASCO education podcast. I'm Pat Loehrer, Director of Global Oncology and Health Equity at Indiana University.
And I'm Dave Johnson, a medical oncologist at the University of Texas Southwestern in Dallas, Texas. Pat, we have a terrific guest today that ties in very nicely with your interest in global health. I'd love for you to introduce her.
Thanks, Dave. Battling cancer is truly a global effort, both in research and in treatment. However, there are various degrees of quality in these fields depending on the economic health of a particular region. Our next guest is trying to optimize cancer care in Africa, and we're very excited to talk to her. Dr. Miriam Mutebi is one of the most prominent cancer doctors in Africa. Dr. Mutebi is the first female breast surgeon in Kenya, and she's currently assistant professor in the Department of Surgery at the Aga Khan University in Nairobi, Kenya. And she's on the board of directors for the Union of the International Cancer Control. She has trained and studied at top hospitals in New York and South Africa. Dr. Mutebi is so focused on increasing women's health in Africa that she's trained to be an airplane pilot in order to connect with hard-to-reach areas. Disclosures for this podcast are listed in the podcast page. Thank you so much, Dr. Mutebi, for joining us from Kenya. Can you start us by telling us a little bit what it was like growing up there?
I grew up in Nairobi, which is a pretty urban setting to grow up in. So most of my childhood was spent, I think it was probably a much simpler time where, you'd play in the street, go off to somebody's house, spend the rest of the day there and come back at the end of the day. But in terms of growing up, I think I was one of those super nerdy kids, for want of a better word. One of the sort of things that got me interested in reading and learning and challenging myself was actually my dad, because what would happen was we had to go to school about, I would say, almost about 30-kilometer bus ride. And my dad would be like, well, if you're on the bus to be there for that long, you can as well, carry a book and, made it nice and exciting. So I remember sort of discovering the library in my primary school and going like, my word, because you get, access to all these different, experiences and worlds. I mean, you're going in and reading, the Chronicles of Narnia, you're reading about Enid Blyton and different experiences, you're reading all these different worlds and getting to, identify to some extent with, the core values that exist. It doesn't matter where the books were centered. And so that for me was an almost, I would say, idyllic growing up, because for me it was like, yes, books, check, running around, check. That's, I think, what I remember most about my childhood.
It sounds like your father was a powerful influence in your youth. Can you tell us more about your father?
Sure. My dad's, how old is he now? He's going to turn 74. One of the things that he always says, anyways, it costs you nothing to be kind. And so he would generally, I'm just going to stop a little bit. I'm getting weepy.
Oh,
I'm sorry.
It's okay. Shame. Oh, yeah. Dave, you pushed the button.
It's not our intent to push a button. It sounds like your dad's a wonderful person.
No, it's fine. It's fine.
Both Dave and I have daughters, and we feel the same way. So as weepy as you're getting, I can guarantee you that he's going to feel the same way on the other end.
No, it's just that he hasn't been well recently, so it's just
I'm sorry.
Yeah. Yeah, okay, cool. Let me see if I can stop getting a little weepy. Yeah, so one of the things that he frequently says is that it costs you nothing to be kind. And I think that's one of the things that he sort of instilled in us, that you need to think beyond yourself. You always need to sort of think about what is the other person going through and how can I help to make it better. Now, my dad, I mean, he has a really interesting sense of humor. I think it's where I get my cheesy humor from as well. But he always talks about what we call the 11th commandment, which is don't take yourself too seriously. And so I think that was part of the grounding steps that he sort of helped to instill in us, because he was working hard. I mean, sort of looking back, most of our parents, I would say, got married at a very young age and had several kids they were raising. And sort of looking back, you're thinking they're probably just doing the best that they can, right? But I think did a fairly decent job, I hope.
So, Miriam, when did your interest in medicine begin? And who was the inspiration for that, or if there was someone that inspired that?
At the end of high school, I remember I wanted to do 5, or rather, was it 6 different things? And so I wanted to do medicine, I wanted to write, I wanted to do architecture, I wanted to do law. I even forget what the other things were. There were like 2 other things on my to-do list. And I think part of the genesis of that was because as part of the high school training that we go through, we had to do the international sort of baccalaureate. And what that entails is you have to do components of creativity, action, and service. And so at the end, I'm like, again, falling back to Father Dearest. And I'm like, Dad, I have 6 different things I want to do and I don't really know about it. And like, so why don't you spend a bit of time sort of just going through each of those, like shadowing there's different specialities. And so we managed to track down his lawyer friend, spend time in the hospital, spend time in a pharmacy, just shadowing the pharmacist. Actually went to work briefly for a publication house. So eventually, and and architecture as well. So then I managed to narrow it down to, yes, okay, I want to do medicine and I want to write. And so went back to my dad and said, Dad, okay, I have 2 things I want to do. And my dad was like, well, if you do medicine, you can write. But if you write, then you might not necessarily be able to do medicine. So that's how I sort of wandered into medicine. Although I still say there's still the great African novel waiting to get out. But again, with medicine, I think I'm guilty of what we call end of rotationitis, where at the end of the day, you finish a rotation and you're like, I can do this. So I think going through different rotations, I think for me, the slow narrowing down to surgery was really around, unfortunately, the time when we were doing our rotations. And this was just really at the start of the 2000s in Kenya. And the challenge around that time was we're really just at the tail end of the HIV epidemic. And not everyone had access to antiretrovirals. And it was an incredibly harrowing time, I would say, for the healthcare profession, just because there's still a lot of stigma around HIV. And what was happening was that you would go to the wards and find patients had been abandoned. And there was a general sort of pervasive sense of hopelessness because people didn't have access to the medication that had been abandoned. And unfortunately, not much was being done in terms of active management of patients, whereas then that was like on the 7th floor, and then you would go down to 4 floors down to the surgical ward where patient comes in, they're bleeding, you take them to OR, they get better, you send them home. And so for me at the time, it was like, I need to do this. At least I could see where I was sort of making an impact. And so that's how I sort of wandered into surgery. And I'm sure, as I said, with of course the developments now, their experience, of course, for medical rotations is entirely different, but that's how I sort of ended up in surgery. But then how I sort of found myself in breast surgery was actually because for me, what stood out about my breast rotation was really looking at what we were reading in the textbooks, which was breast cancer is a disease of the 6th and 7th decade. And the quote unquote poster child for this is the elderly nun who's never had any children, who's had this, prolonged estrogen window. And I'm sitting there and looking at the clinic and I'm like, these patients are, in their 30s and 40s, all of these traditionally protective factors, like, having multiple children, having breastfed, ticking all the boxes, but they're still coming in with these kinds of cancers. And so just thinking this is totally different from what the textbooks are saying, and somebody needs to get to the bottom of this. And that's how I found myself going along breast cancer surgery and also research into women's cancers and things.
My sense is that Kenya and many African nations were male-dominated. I don't know what it was like for you going to medical school, but particularly in surgery, it tends to be a male-dominated field. What was that like as a woman in many ways? I think you were breaking some glass ceilings. I'm sure there were other women doing similar things, but tell me a little bit about that experience.
I would say bewildering for both parties. I remember because we had to do several interviews just in different institutions before getting into a surgical residency. And I remember these senior professors sort of peering down their glasses and looking frankly bewildered and asking the most bizarre of questions, which I don't think anyone would sort of get away with in this day and age. I remember somebody asked me, and this one always stands out in my mind because somebody asked me at one of the sort of on the interview route, so what happens if you get a patient in ICU and you start to cry? I'm like, well, first of all, I'm guessing that I'm crying because I'm having a bit of empathy for the patient. And I think that actually probably makes me a better clinician because I am really truly seeing the patient rather than bed X with diagnosis Z. This is like, Mary, mother of 1, 2, 3, and whatever. But it was really bizarre. And then somebody asked me as well, okay, so what happens when you're on call and you have to breastfeed? And I'm like, well, let's see, this is a tough one. You could tell as well that they were really like out of their depth. So eventually I settled on the Aga Khan just because in terms of the faculty and the interviews, I got a sense that they were a little more open to the idea. And that's because I think one of my earlier mentors, Prof. Raja, who is our former chair of surgery, had come in from the Aga Khan in Pakistan. And for him, it wasn't anything unusual to see women in surgery. So like, yeah, come along, we'll train you and stuff. And he was also pretty inspiring in terms of the decision to get into surgery because for him, their approach to at least surgical training, and we always tease him and say we all drank the Kool-Aid because we kind of came back because it wasn't about just, training surgeons for surgery's sake. It's about how do we become leaders? How do you impact care in your region? And so it was never about just learning surgery. It's how do you use the tools that you have in order to improve the health of those around you. And in the Aga Khan, you're sort of, one would say, in a position of privilege. Just the backstory to those listening who might not know about the Aga Khan, it's a private university hospital. But I mean, as a private center, then of course, I would say there isn't any difference, one would say, between the Aga Khan and most of the, international hospitals anywhere in the world. But it was always sort of driven into us that this is a privilege that you're having. And how do you use this privilege to elevate the communities around you?
Well, let's talk about breast cancer, if you will, in Kenya. You mentioned it that when you first went into it, patients were coming in with advanced disease. They still do. But how has the field of medicine changed in Kenya during your lifetime, your professional lifetime, as it pertains to breast cancer?
While we still have the majority of patients diagnosed with advanced disease, the scenario 10 years ago was that patients would get diagnosed with advanced disease and frequently would not complete their care. And if we sort of did a deeper dive into the reasons behind this, we saw a constellation of factors. One being the fact that patients were having to pay out of pocket, frequently resulting, of course, in financial toxicity, catastrophic health expenditure. And then the other major barrier was the health system itself. And again, to some extent, that still exists, where we know, at least on average in sub-Saharan Africa, patients are going to see 4 to 6 healthcare providers before a definitive diagnosis of their cancer is made, which all, of course, again, translates into delays in ultimate treatment. Again, one of the other areas that we frequently don't necessarily talk about as much are the social cultural barriers that exist and to some extent are still pervasive in some communities. And what we see is, one, there's a lot of use of alternative therapies. There's still quite a bit of stigma around cancers. There's also what we call collectivism, where we always say in Africa, our community is our strength, but sometimes that sense of community is a double-edged sword because then if the patient is losing agency, then, I mean, that becomes a real concern, because what we find, for instance, is, I'll give you an example. I'll have a patient come in and, sort of discuss, maybe she has an early cancer, and discuss the options of, do you want to have breast conservation versus a mastectomy? And then you will find maybe she goes home to have a think, and then a couple of days or whatever later, there's community gathering, and the clan elder is saying, we have decided. And I'm like, who's we? It's not your breast coming off. Like, what right do you have to decide on patient decision making? But you see, as much as we would like to sort of say, have the patients have autonomy over their decision making, it's really a question of equity and access to care. Because even if you're giving the patient autonomy, and she's saying at the end of the day, well, they're the ones paying for the treatment, so let them decide what it is I'm going to have, then we haven't really adequately empowered our women. And so those are some of the challenges that existed, I would say, about 10 years ago. We're definitely seeing an improvement, one, in the patient's ability to pay. And this, I think, has been a concerted effort by the government to come up with a national health insurance fund, which initially wasn't covering cancer care, but has definitely helped to ensure that the number of patients who actually complete their care or going through the entire cancer journey are probably more. I remember when I was doing my internship, and these were like truly heartbreaking, because as interns, we were the ones, we would have the internists sometimes, because there weren't that many medical oncologists, prescribe the chemotherapy. And as interns, we were the ones who would administer the chemotherapy. And so you would have a patient come in, and it involved basically, we get the prescription for the chemotherapy, but they also have to buy their own saline, the IV line, and everything else. And then, they get the first cycle, and then they just disappear. And and then those are the times they weren't necessarily, mobile phones weren't that common. They literally just disappear, but then they come back 6 months later, and they're like super excited. And they're like, Doc, we've raised enough money for the next cycle. And we're like, well, it doesn't quite work like that. So with the National Hospital Insurance Fund, it's not perfect, but we're definitely seeing more patients going through the entire care continuum, which is gratifying. I'm sort of putting on my Kesho hat as the chair of the Kenya Society for Hematology and Oncology, and saying we've been working closely with the National Cancer Control Program, really to advise the National Hospital Insurance Fund on sort of maybe getting more comprehensive covers. Because what was happening initially was, for instance, they would cover maybe 4 cycles of chemotherapy. But then the patient has to come up with the remaining 4, for instance. And sometimes if they're not able to afford that, then you're sort of giving them the side effects without the therapeutic benefits of some of these. So they are currently in the process of really looking more at treatment plans. And that's also been at least and then the fact that they're willing to listen has also at least been a huge stride. And then, of course, in terms of the real efforts, I would say, by the National Cancer Control Program to ensure some of the decentralization of cancer services. Initially, we had only one radiotherapy center at the tertiary referral hospital in Nairobi, and that was having patients, traveling from across the country, 400 kilometers or more, coming in. And, you come in from a rural area, you come to Kenyatta, and somebody tells you you have to live there for a month. You have, no family, nowhere to stay. People say, you know what, I don't need to have this stage, or rather have this, additional treatments. And so with the deliberate development of or decentralization of the radiotherapy services, we now have at least regional centers in planning. And so really looking at how do we bring the services closer to people. And so we now have, in addition to the tertiary referral centers, we now have 2 regional centers in Mombasa and name is just gone.
Eldoret.
Yes. I think beyond Nairobi, Eldoret, we now have a comprehensive center in Mombasa. Nakuru's just launched a comprehensive center, and Garissa as well. So really looking at enhancing our capability to bring these services closer. And there've also been the development of the chemotherapy units across the country that has also at least tried to ensure that these services are more readily accessible to populations. And then really just, underpinning that with the support from the National Hospital Insurance Fund has helped to basically have more patients completing their care. One of the other things that I think deserves particular mention is really the grassroots advocacy that has really tried to increase awareness around cancers. And as a result, we're definitely seeing, as much as we're saying the majority of patients are still diagnosed with advanced disease, we're definitely seeing the entire continuum, I mean, all the way from, screen detected tumors, early stage 1, stage 2 cancers to more advanced tumors. So that also really shows that there is an continuing consciousness that's really sort of driving this education efforts and awareness in the community. Of course, we definitely do need to do more because we still see that the advocacy efforts sometimes tend to center largely around urban areas. And of course, the question is, how do we then sort of percolate that down to more rural areas? It's definitely something that's improved in the last 10 years. And then, of course, we've also seen an expansion in the cancer workforce. And that, I think, has also been largely driven by the fact that we're having in-country training for clinical oncology, medical oncology, gynae oncology. So we're really thinking about how to expand the workforce. But of course, we're still looking at the patient to population ratios. Those are still pretty low, and we still recognize that they are deficits along the care continuum. But we're now having pharmaco-oncologists, we are having psycho-oncologists, increase in palliative care specialists. So there's definitely been an exponential growth of all cadres of healthcare providers, whether it's oncology nurses and things. We've had an oncology nursing chapter now that's been developed. We're really seeing the rise of the professional societies like the Kenya Society for Hematology and Oncology. And there's a lot of crosstalk between the academic institutions that are running the oncology training program. So it's really a positive move in the right direction. But I think what needs to happen is, as I would say, more deliberate investment in the workforce, because again, even as we increase the spectrum of the oncology workforce, there's really a need to carry along the primary care providers, because they invariably are the gatekeepers to access. And so unless the primary care providers are empowered and knowledgeable to facilitate early and timely diagnosis and referrals to the appropriate pathways, then it doesn't matter how many people, how much of the workforce you have on top of a pyramid. It just means you're invariably going to be still getting patients diagnosed at later stages. And so there's also been efforts around that to come up with primary healthcare provider courses to educate on common signs and symptoms. And this is something that the Kenya Society of Hematology and Oncology has been doing in collaboration with the National Cancer Control Program. There's deliberate effort to come up with an online platform that actually are able to give real-time information to primary care providers. And so I would say there's definitely, steps in the right direction, but there definitely needs to be more investment in the entire spectrum of care.
Miriam, what you've done is astonishing. I mean, you've built, what you've just described, an amazing infrastructure in a relatively short period of time. I mean, what you're talking about took us in the United States half a century. You're trying to do that in a matter of 5 to 10 years. You've trained in both Kenya and in the United States. I wonder if you might just take a few moments to compare and contrast those experiences.
In terms of working in different spaces and sort of working in the US, working in South Africa, working in Kenya, what you realize is perhaps a very different patient profile. Whereas in countries like the US, where you have vibrant screening programs, then you're definitely having a lot more discussions around 4mm, 5mm tumors that are you doing an MRI guided biopsy for, and maybe a lot more screen detected tumors. Whereas working in setting, especially when you get out of the urban areas, whether it's in Kenya or South Africa, you find that you tend to have a lot more diagnosis of patients coming in with fungating tumors and advanced disease. And so it's really that spectrum. And that's what I'm saying in terms of the current state of flux that we're in. We're now, as clinicians, at least in working in Nairobi, you're sort of seeing the entire spectrum and much less and less of the sort of fungating tumors. So I think in terms of the principles, the good thing is that irrespective of where you are, principles do not change, but I think you sort of have to rapidly innovate and iterate in settings where you may not necessarily have a, say, MRI to do an MRI guided biopsy, but you also sort of look at what makes sense for the patient. Working in lower resourced settings, I think, is actually a good thing because it challenges you to constantly think about value-based care. People talk about value-based care as a concept, but you're doing it on a day-to-day basis, even between different patients on clinic, because you have to think about the cost and you have to think about how do I deliver care that's still of good quality, that's not necessarily going to break the bank. And so these are, I think, some of the more challenging or at least questions that we have to think about deliberately. Whereas in the US, if you have insurance, then, pretty much carte blanche, for want of a better word. But what we did realize, especially with COVID, and I'm sure Pat and Dave, you can bear testament to this, is that these disparities exist globally. And so you'd find that patients who have no insurance or are underinsured are still coming in with the same sort of challenges. And I mean, I was talking to my colleague at NYU who works at Bellevue, and she was giving me the profile of her patients, and it was interesting to see that there wasn't really, and these are patients who don't necessarily have insurance, there really wasn't any difference from the images that we're seeing and the patients we're seeing. So really, it's an opportunity for us to sort of rethink collectively our approach to care and really thinking about how do we provide quality care.
I was in Washington this week, and President Biden had a 3-day African U.S. summit. And at the end of this, he basically pledged to spend $55 billion in Africa to help relations with them. We also had a discussion about the Moonshot 2.0, in which President Biden wants to end cancer as we know it, with a particular emphasis, I think, and now in linking with LMICs. Briefly, what would you tell President Biden in terms of what would be very helpful for the United States to help with the cancer problem in sub-Saharan Africa? What would you say in a sentence or two?
As we say, perhaps have the moonshot, but stay grounded in the sense that even before we think about complex molecules, we are still struggling as a continent with the basics of care. And so investing in health systems and the basics will ultimately give more or improve outcomes rather than sort of focusing on specific molecules. So if we have the basics in place to deliver the basics of care, then that would go a long way towards shifting outcomes. The other bit that does need to happen is, again, with research, because there is a paucity of cancer research. We did a recent bibliometric analysis and found that as a continent, we're only contributing to less than 8% of all sort of cancer research globally. And we do know that, one, we have, I would say, the breadth of diversity in terms of genetic diversity. We do know that the responses to care and treatments are different. We do know that we do need to think about implementation science and what structures we can put into place and what strategies, what works in different settings might not necessarily work in ours, and it does need to be backed by evidence. So there is opportunities to expand care and strengthen systems, but really do this in an evidence-based, pragmatic way that ultimately assesses its own outcomes and outputs for the patient.
Thank you for that, Miriam.
Well said. Thank you.
Great advice. I hope the president is listening.
Dr. Mutebi, what was your first book that you remember that you loved?
I think it was actually The Lion, the Witch, and the Wardrobe. For some reason, it was just the whole sort of just stepping into a different world. And then, of course, we all had crushes on Aslan, the lion, but it was more because he was like this, guy who would swoop in and, morally just and get to mediate the world. So I went through the whole series, just gobbled it down. And then I think that's one of the things that really stands out for me as one of the books that I sort of remember early on.
It's such a great pleasure today. I'm really excited. We typically talk about books, and here's a book, Dave, I know that you have not read. It's entitled 101 Things I've Learned in Engineering School. It was actually an interesting book. As you know, I'm an engineer background, but there were a few quotes in here that
I live on Purdue Avenue, so I have some engineering background.
Oh, that's true. Good for you. So you might like this one, Dave. One of the quotes I have is, inventing is a mixing of brains and materials. The more brains you use, the less materials you need. The other one, the difference between accuracy and precision, they're really different things. And so the best example they came from the book, which I thought was interesting, was pi. So pi is what?
Round.
Okay, this is going to be painful. Pi is 3.14, right? So that's accurate. But if you say pi is 3.14159265535, that's accurate and precise. And if you said pi is 3.98, that's just inaccurate and imprecise. As I think about engineering as we move forward, I'm thinking about the lung pragmatic trial that has just been announced, where we're trying to do trials a lot more simply, in which I think we can be accurate, but perhaps not as precise as we always deemed to be important. And I think that we're real excited about that in that project.
Well, that's really all the time we have for today. And we really want to thank you, Miriam, for a wonderful interview. And knowing that you're up very late at home makes it all the more special. We also want to thank our listeners to Oncology, etc. This is an ASCO educational podcast where Pat and I will talk about just about anything. If you have an idea for a topic or a guest you'd like us to interview, please email us at education@asco.org. Thanks again. Pat, I have an important question for you before we leave.
Mm-hmm.
What do you call a snail that's not moving?
You got me, man.
Escar stay.
I love it. Miriam, asante sana.
Nimeshukuru. Shukran.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.